Hello, I am Amy Shaheen, and today I'm going to talk to you about medical students and community practices, demonstrating bi-directional value to improve practice recruitment, patient outcomes, and student learning. What are the problems? Medical students should be learning in community practices where 95% of healthcare is delivered. Currently, less than 10% of learning takes place, though, in community practices. This is because ambulatory clinicians who should be hosting those students are burned out due to the competing demands of practices, including new electronic health records, population health reporting, and the paperwork that goes along with being a doctor. The health systems that employ these physicians also don't support having learners or clinicians in this environment to host learners because they don't see any value in medical students. However, students are required to learn quality improvement and population health methodologies. And ultimately, we all need more primary care physicians. So the aim of our study was to demonstrate the value of students to practices and to teach, and the way we did this was trying to align the curriculum with the practice needs and to align any student assignments with the practice population health needs. And the way we did this was to teach quality improvement methodology using the model for improvement and teaching students to apply their learning to the population health needs of the practices. We also did concurrent faculty developments on quality improvement methodology and also on how to choose a project for a medical student. Every trimester, we need 50 learning sites for our students. Of course, our students prefer to stay locally, but even our own UNC-affiliated practices have historically had very low engagement. You can see here that community health centers typically in our area had 4 students per block. With our intervention, they were able to increase this to 12 students per block. The UNC-affiliated practices generally have 1 to 3 students per block, and we've been able to increase that to between 12 and 17. As you can see, we still have room to grow. But what about the patient population health outcomes? We looked at many metrics that the practices already had available. As per our suggestions, students worked on practice priorities. These included things like cancer screening, falls prevention, chronic disease management. We were also able to see the impact of students in a variety of practice types. I have decided to show just a few of those here, and these percent improvements that you see were over 1 year. As is typical, practices like those in the Primary Care Improvement Collaborative that already had high performance showed less improvement, but it was still significant. For example, if the other Primary Care Improvement Collaborative practices covering the 50,000 patients that did not have a student improved as much as the Primary Care Improvement Collaborative practices that hosted students, that 1.5% improvement translates to 750 more patients screened annually, as well, and that could result in up to 22 lives saved over a lifetime of screening. If you looked at the non-PKIC practices that have less robust improvement environments, the impact of students is even greater. Finally, if you look at community health centers that serve the indigent, the non-insured, perhaps the undocumented or non-English speakers, you can see that they also, if they hosted a student, had more improvement than those who did not. And these gains were seen across a variety of metrics, and I've shown a couple more here. So I've shown colon cancer screening, breast cancer screening, and cervical cancer screening, but there was improvement across a wide variety of metrics. In summary, students can learn to apply quality improvement methods to the outpatient settings. Student efforts can lead to real improvements in population health, and the health systems, I believe, will be much more likely to embrace students if we can continue to demonstrate their value to the practice.